what I say,
Cannot be. But I'm gonna ask you why you said this patient is alert and oriented.
I know, sir, it can be. Because me look at the point, say, him answer the question when you ask him his name. But the fact say him slip back into a state where him no.
Right.
So,
Patient is only responding to your voice, verbal stimuli. That's not a patient that's fully alert
yes, sir.
and oriented. That's a patient that's responding to verbal stimuli, right? So that would be the representation of verbal stimuli. Now, you have the same patient, right? So you have the same patient, you enter the room, the patient is lying in bed, supine, eyes closed. You approach the patient, he says, "Sir, can you hear me?" Patient doesn't respond, right? So patient is not alert and oriented. Patient doesn't respond to verbal stimuli. You then apply pain to the supraorbital nerve. That's the ridge, just above the eye socket. There is a ridge right there, right above the eye socket. You find the supraorbital nerve. You put pressure on that nerve. That's one point to apply pain. You can pinch the neck. You can twist the ears. You can do a sternum rub. You can put pressure on the cuticle of the nail, right? Now, the places that I prefer to apply pain is supraorbital nerve or the cuticle of the nail. I'm not an advocate of a sternum rub, right? A matter of fact, it's no longer taught in EMS. So the reason for that is very straightforward, right? Sternum rub, when you do a sternum rub, it can elicit a spinal reflex. What do I mean by that? So you can do a sternum rub and you get a spinal reflex. It doesn't mean that the signal is reaching the brain. When we're checking for pain, we want to determine if signals are going to the brain. So it's better to apply pain to an area where the signal is going to move back and forth to the brain than through the spine only, right? A spinal rub might not be appropriate for certain patients. Sorry, sternum rub, right? So you have the options. Now, when you apply pain, the patient groans, right? So you apply pain wherever, supraorbital, pinch the neck, ears. I will never use the ear as a pain source because I don't think that's painful. You can pinch the neck, and as I say, you can put pressure on the cuticle and the nail. When you apply pain, Mr. Cameron, your signal is still low, so I don't think you'll be hearing anything that I'm saying right now. When you apply pain, the patient groans. Is this patient alert and oriented? Powell, would you consider this patient to be alert and oriented?
No, sir.
Cameron, and the signal still not good enough. Go
No,
ahead.
we are here now, sir. It's in and out, but we are get most of what you say.
All right. Did you hear what I just said with the patient responding to pain only?
Yes, sir. I hear the part where you say no longer using sternum rub because it sends a a signal to the spinal column, get a spinal
Yeah.
reflex.
It can elicit a spinal reflex action. That's
So-
not what we want to determine. We want to determine if signals are still going to the brain.
Yes, sir.
All right, so would this patient be alert and oriented if they're only responding to pain?
No, sir.
Okay. Good. Yes, Mr. Powell.
Yes, sir. Question. In regards, you were talking about the different areas where you check in respond for pain.
Yeah.
Say, for example, a patient, a diabetic patient who you know might be, well, you wouldn't know, but might be experiencing diabetic neuropathy. What would be some of the areas that you recommend to check the for pain response in these kind of patients?
The same areas that I just recommended is either the patient will respond to it or they don't. And if I am applying pain to a patient and the patient is communicating with me and not feeling that sensation, then it means that there is decreased sensation in that area, but the areas don't change. They will remain the same. You got that?
Sir. But is well, in regards to most diabetic patients, when they're responding to them, they would be like unconscious due to either high blood sugar level or low blood sugar level, right?
Not necessarily. You'll find a diabetic in that state when it gone bad. Right? So the patient can still be responsive, but they are combative or confused. It doesn't necessarily mean that the patient would be unresponsive at that point. If you find that your diabetic patient unresponsive, then serious trouble.
All right, sir.
You have a better chance if they are somewhat responsive but confused or disoriented. When they're not communicating, they're not in good shape.
So the question is along the line of the basis of you accurately grading someone who is, say, probably, example, in diabetic, who is a diabetic, who based on the neuropathy or the decreased sensation of the nerves.
But I just said to you, is either the patient will respond or they will not. That's it. So there is no other option outside of what I've listed for ascertaining pain. And it's either the patient will respond to the stimuli or they will not. And if they don't, you document accordingly and manage accordingly. So the point is this: I'm not concerned about a diabetic with decreased sensation. That's not something I would be worried about. I would be worried about, is the patient blood sugar too low or too high, and what are the repercussions of that, right? So it is either you use the options available and it gives you a response, or it don't. So there's no other alternative based on the question that you're asking, right? Not to my knowledge anyway. So was the question answered? Yes, somebody answered the question. So if the patient is only responding to the painful stimuli, then it means that the patient is not awake, alert, and oriented, right? Now, if you have the same patient, get a call, elderly patient found in bed, patient doesn't seem to be responsive. You approach a patient, hello sir, you don't get any response to verbal stimuli. You apply pain, patient doesn't respond to pain. What is your assessment findings at this point, Mr. Manning? patient isn't alert, the patient not responding to verbal stimuli, not responding to pain. What is your assessment at this point?
At this point, the patient would be unresponsive.
All right, so your patient is unresponsive. A very important question. Think about it before you answer. If you have ascertained that this patient is unresponsive, what does that mean to you? What are you concerned about at this point?
Okay.
Hold on, Mike Wilson, Mr. Wilson. What would you be concerned about at this point?
Well, sir, at this point now, being that the patient unresponsive, so you have to worry if anything is being compromised in terms of like circulation, airway, or breathing.
All right, I hear you. Mr. Cameron, you can still hear me? Cause the signal dropping, signal in the red. Can you hear me?
Yeah, but it's in and out, Mr. Opus.
All right, so it's definitely a problem on your end there. As see, they're gone again. All right, Mr. Manning, what would be your concern?
Yes, sir. As I think it was Mr. Lewis said earlier, it would be straight into airways because I would be wondering if that person is, or I would assess to make sure that person is breathing properly to see if they're ventilating, if basically the whole airway, checking to see if the airway is blocked, as that could lead into more serious things. So I have to check that first, airway assessment.
All right. All right, so let's recap. First assessment we do or conduct for every patient, regardless of whether it's a medical or trauma patient, will be we ascertain the patient's level of consciousness. This is the first vital sign we evaluate, right? You will use the AVPU acronym, AVPU. For now, I will add GCS later, Glasgow Coma Scale. For now, AVPU. The A is alert and oriented. So we look to see if the patient is alert, awake, right? And we check their level of orientation to person, place, time, and event. If the patient is not showing any signs of confusion and follow you as you move around the room and interact with them, you just need to ask 2 questions. What's your name? Can you tell me what's going on with you today? Why you need EMS? If the patient shows signs of confusion, then your questions become more specific to person, place, time, and event. If the patient doesn't seem to be alert or awake, then you will check to see if the patient responds to your voice. If the patient responds to your voice, they are responding to verbal stimuli, right? If the patient does not respond to verbal stimuli, you will apply pain, either at the supraorbital nerve, right? Pinch the neck, twist the ear, or based on your protocols, a sternum rub. And remember what I said, sternum rub is not a part of EMT curriculum anymore. There are still some services that allow EMTs to do it, but it's not a part of the curriculum. It's not accepted in the curriculum anymore. Or you put pin on the cuticle of the nail. That's the base of the nail, right? If the patient responds to any one of those painful stimuli, then it means the patient is responding to pain. So more than likely, a patient is semi-responsive at that point. If you cannot get a response to pain, right? and the patient doesn't seem to be awake or oriented, then your patient is unresponsive. Once you classify your patient as unresponsive, it means that your patient has a problem that can kill them, right? So once you have a patient that's unresponsive, that patient has an issue present that if you don't fix it, this patient will not survive. So when a patient goes unresponsive, the muscles that control the tongue will relax. When these muscles relax, the tongue will then fall back into the ear passage. And when the tongue falls into the ear passage, these two things can happen. It's either the patient have a partial airway obstruction or a complete airway obstruction. If the obstruction is partial, you will hear snoring. If it's a partial airway obstruction, you hear snoring. If the tongue is completely obstructing the airway, you will hear nothing. Right? So your patient has a compromised upper airway. And if you don't fix that, your patient is going to die. Right? So if you cannot fix that problem, the patient is not going to survive. Now, once you start to anticipate upper airway obstruction, you start with mechanical procedures to correct that, right? Now, is either you will perform a head tilt chin lift or you will perform a jaw thrust maneuver. The head tilt chin lift is for when you suspect no spinal injury. So when you don't suspect any type of spinal injuries to your patient, you will do a head tilt chin lift. If you suspect that there is the possibility of spinal injuries, you will do a jaw thrust maneuver. Right? Any questions so far? All right, so if you have no question, I have questions. So, Mr. Poyle, if your patient is found to be unresponsive, what's the first thing you're concerned about?
If the patient is unresponsive, the first thing I'll be concerned about is the patient's airway to check if it's blocked.
Okay, what would you be anticipating in the airway?
The tongue muscles being relaxed due to decreased brain function.
The tongue. All right, good. Mr. Manning, if you suspect no spinal injury for the patient, what method would you use to open the airway?
All right, if there is no spinal injury, then I'll go with the head tilt chin lift.
Okay, Mr. Wilson, you suspect spinal injury, what method would you use to open the airway?
Jaw thrust maneuver, sir.
All right, I don't know if Mr. Cameron is present. Or you guys stay on that side and you can't hear me now?
Yes, right here.
All right, so my question to you guys on Mr. Cameron end. If you do a jaw thrust or a head tilt chin lift based on the patient presentation, and there is no chest rise, what would you do next? So you position the patient's airway, where you open the airway, you look, listen, and feel there is no chest rise. What would you do next?
Chief. Up. Come on, touch it.
Go ahead.
Dr. Rufus.
Yes, sir.
All right, Johnson here. Now that case, the two respiratory, see no movement I chest, no lateral movement, bilateral movement that I chest.
All right, cool. So that's Johnson, right?
Chief.
Who was that? Johnson?
Yes, sir.
All right, so this is my question to you, Mr. Johnson. You have a patient that's unresponsive. You have performed either a jaw thrust or a head tilt chin lift, depending on the indication. You look, listen, and feel, patient not breathing. You know if this patient is alive? That's my question to Mr. Johnson. You know if this patient is alive?
Repeat the question, I can't hear you. Because we think I not break up on then.
All right, listen carefully. Based on your words, the patient is unresponsive. You have performed a head tilt chin lift or jaw thrust based on the patient's presentation, right? The patient is not breathing. Do you know if this patient is alive?
No, wouldn't know if the patient alive. I check for the pulse now.
All right. So if there's no indication of breathing, definitely you need to find out if the patient still has a pulse going, right? Because why? Respiratory and circulatory system is connected. That's why we went through all of that yesterday. You can't assess one system without assessing the other, right? So you would need to determine if this patient have a pulse. As if the patient don't have a pulse, then you're going into CPR. If the patient has a pulse, then you focus on the airway issue, right? So that's the purpose of assessment and being sequential. All right, so my critical thinking question now. So this is my critical thinking. I have indicated to you that when your patient is unresponsive, muscles that control the tongue relax, the tongue fall back in the ear passage. You can remove the tongue mechanically by positioning the head using the head tilt chin lift if there is no spinal injury, and the jaw thrust maneuver if there is spinal injury. My critical thinking question to you is this. What if the jaw thrust is not effective? So let's say we have a patient with suspected spinal injury, but the jaw thrust maneuver is not effective. What would you do at this point? That's a critical thinking question. Anybody have an answer yet? Or you want to sleep on that one and come? Right, so head tilt chin lift being indicated for no spinal injury and jaw thrust being indicated for spinal injury is what we call textbook presentation or black and white. However, what if there is a gray area? The gray area is you suspect spinal injury. You try the jaw thrust maneuver, but it's just not effective. What do I do at this point? What are my options? And as I say, you don't have to answer it no. You just need to be thinking about it. Yes, Mr. Cameron.
All right, from Cameron and Johnson.
Go ahead.
All right. You know the case when you say we do the jaw thrust, might not work.
Yeah.
I guess you gotta use maybe the them mechanical aid thing the J tube or you want to call it. A scope or
Yeah, go with your hope, you know. When I reach advanced yet.
that's
When I
about
reach
it.
advanced.
So, all right, sir.
Yes,
George here, sir.
go ahead.
Sir, if that is the case, then, sir, I would use the term life over limb. So I would have to proceed back to the head till jolly, even though head till chin lift, even though there is a spinal injury, sir.
That is acceptable. Right? So you would do what is called a controlled chin lift. You're gonna do a head tilt chin lift, and it's slowly, and you're doing it to a point where you have enough room to place an airway adjunct in the patient's mouth. And ear adjunct or airway adjuncts will be the next discussion. Not today, but that's where we're going. So yes, that is acceptable. Right? We have to do something. Now, whoever said they would go back to the head tilt chin lift, would you inform medical director, your medical director, or would you just go into the head tilt chin lift?
Sir.
Yes. Yes.
Yes, sir. I agree. We still have to contact the director.
Yes. Most definitely. Most definitely. Right? So good. Good. We're thinking. We're thinking. I like the thought process. Right? So this is the first. This is the first phase for you to get familiar with. Right? And some of what I've explained might be things that you might already be familiar with, or things that you have already you have been implementing in your everyday work or experiences. However, what I want you to pay attention to, even if it's something that you already know, is the sequential approach that is being used. That is what is important, right? The sequential approach. How we ascertain the orientation, verbal, pain, what we consider when the patient is unresponsive. When we position the airway, we check the airway, right? So you position the airway, you check the airway. Because breathing and circulation is connected. If there's no movement at the chest, you have to check circulation. If there was movement at the chest, then you evaluate the chest movement, right? So once breathing is present, you check breathing, then circulation. That's where we're going. That's where we'll leave it for now, right? Are there any questions? All right, cool. All right, so we're good to go. We're good to go. All right, so let me take a quick peek at the timetable to see what's on the timetable for tomorrow. I think it's lifting and moving and something else. I can't remember. Let me just double check that. All right, it's taking forever to come up. All right, so my next question now, while that is taking some time to come up, you ascertain that the patient is unresponsive. There is no spinal injury suspected. you perform a jaw thrust maneuver. No, not a jaw thrust, a head tilt chin lift maneuver. The airway is clear, and after you perform the head tilt chin lift, the patient demonstrate that he has visible chest rise, right? So after you do your head tilt chin lift, check that the airway is clear, your patient has adequate breathing, but the patient is unresponsive. What would you do at this point? So the patient has adequate breathing, but is unresponsive. What would you do at this point? Want to challenge to take that question. Let's see who that is. What's that? Go ahead, Mr. Paul.
So they check the airway and breathing, sir.
What was that?
You said you check the airway and the breathing. So the next thing would be circulation.
Okay. Yes, but I'm asking you, well, let me not say anything further yet. Cameron.
All right. Yes, sir. Johnson. All right. The reason this thing happen, I look at practical side. So if you do all of that and you find out say the patient start ventilate, yeah? Right. We don't know if we fall back in an unconscious state. So there are two things. Man. So there are two things can happen after that. Maybe you fall back in an unconscious state. And so you know, maybe if you put him in a recovery position, or you have to put in a tube for maintain the airway open.
Don't love patients, am I? Anyway, yeah. All right. You are correct. Right? You're correct. You are correct. If the patient is unresponsive, you position the airway and you recognize now that the patient has visible chest rise and it's okay, right? You're gonna assess that chest rise. So you need to know the rate, the rhythm, the quality and depth of that chest rise. You need to know pulse ox reading as well. Based on that finding, you'll make a decision to give the patient some form of oxygenation if it is necessary. And it would be acceptable to put this patient in the recovery position. And yes, once you have addressed the upper and lower airway, the next phase would be you assess circulation, right? So the point is this. If you're assessing the patient's airway and there is a problem, you don't move until you have addressed the problem, right? The only time you will move from that area is once you have addressed the issue. And as I say, you're correct. If the patient is unresponsive and showing signs of adequate breathing, the fact that the patient is unresponsive, if they remain supine, the tongue can obstruct the airway again. So you're gonna have to consider how you're gonna keep that tongue out of the ear passage. Recovery position is an option. Depending on whether or not the patient has ventilation problems, you will consider airway adjuncts, right? All right. So, yeah, that is my 2 cents for today. Any questions? Okay, we are going to wrap it up here now. Calling it a day. Any questions? Yes, Mr. Cameron.
All right, Johnson here, sir. It's not a question. Tomorrow morning, I have a dental appointment over the clinic, so I absent for your party in the morning.
No problem. All right. All right, it has been kind of a long day, right? It was long and short, I will say. We're finished with the human body, so I think it's lifespan development and lifting and moving. I think that's what is on the timetable. Let me double check. Yes, lifespan development, lifting and moving. And we're going back into some airway discussion. So we're going into introduction to the airway. All right, people. I think that's it for today. I will see you guys tomorrow if you have no further questions.
Well, not a question for say. Before the rest of the team leaves, I already mentioned earlier you have like a WhatsApp study group or collaboration where you can share information. I don't know if you could add me to that one for the camera and the rest of them.
I have nothing to do with the WhatsApp group.
Sir Rufus.
Yeah,
All right. Would I like to get a number for some of the other person? Like who in I group? Manning, let's see on it. Louis. What the other?
communicate by chat. So do that now.
Let them
Alright.
alone in the chat we have now.
All right, I'll put mine in the chat right now.
Yeah, would I like a number for you two, boss?
Who? Who?
You, sir.
Who are the WhatsApp group?
Boss,
No, your group of different, man. Executive group, you're there.